it's me again, and it's me again with urinary diversion. I guess by the time now you all know that my heart really beats for urinary diversion, and it's really the management of these patients that makes the difference. So we are going to talk about late complications. Yes, there are a lot of late complications. Up to 60% of these patients will have late complications. Typical complications are urinary tract infections or bacteria in about 30%, pyelonephritis in up to 20%. Incomplete emptying residual urine, we talked about 10 to 30%. In women, it can be higher. Ureteroenteric strictures, 10 to 15%. Stones in up to 60%. Upper tract stones are much less, around 10, but bladder stones, incontinent cutaneous, are a problem. And ruptures, which can be a difficult complication to deal with. People always talk about metabolic complications. Well, no, it's not a complication. It's just a consequence of having intestinal pieces in contact with urine, and the amount of acidosis you get will depend on your renal function, the amount of urine, and the surface that it has contact with and the length of contact. So residual urine staying in the urine will automatically cause some acidosis. Now, a typical patient, the 78-year-old male, he's had a bladder substitute for about 10 years. He's not been feeling well the last couple of days. He went to his general practitioner. He checked the urine, gave him some antibiotics, but it's not really helping. His fever is rising. He's getting more and more flank pain. He comes in on ultrasound. He has a discrete right upper dilatation, no residual urine in ultrasound. His urine is nitrite positive with a lot of light leukocytes. He gets a diagnosis of right ascending pyelonephritis, put in a catheter. The catheter has to be rinsed 3 times a day to evacuate mucus, and give him IV antibiotics. On the sideline, he's complaining of nausea and vomiting over the last couple of days, and that would be a sign of metabolic acidosis. You do a venous blood gas analysis, and you will find that his base excess is negative at -5, which means he needs substitution with sodium bicarbonate. This patient probably is already on about 3 grams, so we would give him some IV to compensate for the momentary situation, and his nausea and vomiting will improve. And when we put the catheter in, we realized that he had 150 mLs of residual urine, so this is probably part of the problem. Now, if you look at the literature, this is a comparative study looking at occurrence of infections in conduits and orthotopic neobladders. And these patients have a 3-year follow-up. And they found that actually there's no difference except in the initial phase. And these patients all went home without antibiotics. If a neobladder or a conduit, no antibiotics. And this is the phase where you're still enlarging your neobladder, so your pressure is higher. You've removed the catheter. You probably have some bacteria there because of the catheter, and these patients tend to do that. Another study by Clifford from USC, they didn't have the same phenomenon. They have 11% throughout. Well, their neobladder patients go home with antibiotics. So in the early phase, it can be helpful to give them a phase of protection against infection. We looked at patients living for more than 10 years, 10 up to 20 years. And you can see that the rate of lower urinary tract infections increases. And this is the aging patient not spending so much time emptying the bladder, maybe not as strong as he used to be. So they're getting more lower urinary tract infections, and this obviously can lead to upper tract infections as well. And what we found is that these infections are often associated with residual urine. What I talked about, it's often difficult to diagnose what is really an infection and what is not in a neobladder. And we did see when we look back at 45 patients, they often develop incontinence. There's some kind of irritation of the intestinal wall causing some contractions, which gives them incontinence. And that, a patient coming who's all in doing well and says, I suddenly have incontinence, go and look for an infection. Treat the infection, and their incontinence will improve again. What are the causes of residual urine in a late stage of the bladder? Incomplete emptying is sometimes patient compliance. I've had a patient come in and said, it's great. I go to the toilet twice a day when I get up in the morning and when I go to bed at night. Well, his bladder could hold 1 liter and he couldn't empty it properly anymore. And that, in the long term, will cause problems. So they need to empty their bladder regularly. They mostly have no sensation, so 4-hourly intervals gives them about the 500 ml, and that is the best way to empty it completely. Mucus blockage, but mucus blockage is usually if they have to catheterize and don't evacuate. Patients that can void spontaneously don't have mucus blockage unless they have an infection. That will cause more mucus, and then it can end up in blockage. And then always look for mechanical causes. You sometimes, if you fill the bladder, pull back your rigid cystoscope, and you can do a rigid cystoscopy in these patients because they don't have a prostate anymore. You go in and you empty it, and you can see a mucosal flap fall in front of the outlet. The other things are an anastomotic stricture, urethral strictures, and what we sometimes find, because we really try to spare the membranous urethra, we do sometimes see a residual prostatic tissue. And this can all be treated. Transurethral resection, you can actually resect this piece of mucosa, leave a catheter in for 10 days, remove it afterwards, and see if their voiding improves. Urethral incision, the prostate can be resected. You just have to be careful because you're pretty close to the sphincter, so do it in small steps. We sometimes tell the patients, we're going to do salami tactic. We'll try, see if it works, and if it doesn't, we'll go back again and take a bit more away. And they can understand it because they all don't want to end up incontinent. We went back and looked at these living for more than 5 years. We found that 13% did have an obstructive voiding problem that was treated, and the majority recovered again. 2% remained with a catheter, but everybody else recovered. So it does help to check if they have these problems, and it can be treated. The other common problem is anastomotic strictures. Now, unilateral strictures are usually a stenosis of the ureteral ileal anastomosis, and that's in about 12%. In the newer literature, you find somewhere 25%, and that's usually robotic surgery, and that's usually extracorporeal implantation. If you have a bilateral dilation, think about an infravesical problem or a problem in the bladder. So this is often retention, patients not emptying properly, or rarely you do see a stenosis of the afferent tubular segment. Now, they're always more common on the left side, and the risk factors, as mentioned before a little bit, are longer ureters, which is what happened when you do an extracorporeal diversion. Postoperative urinary tract infection, which causes inflammation and fibrosis. You always need attention-free anastomosis to avoid leakage. That goes together, and the BMI. I personally think the BMI has to do with it being more difficult, you having more tension and leakage, and that's what's causing the problem. How do you treat this? Well, there's the endoscopic treatment option and the open or robotic treatment option. Results for the endoscopic range from 26 to 57% success rate. In our group, we found that if a stricture is under 1 centimeter in length, 50% will recover after endoscopic dilation. If it's greater than 1 centimeter, that goes down to 6%. Open treatment is very curative, 91 to 100%. Again, the shorter strictures have a bit of better success rate than the longer ones. Rarely you will find a bilateral dilation, and it's not quite sure. And here, these are old IVPs. I don't know, do all of you probably don't know them anymore, but you can see that the upper part of the afferent tubular segment is quite clearly dilated, and then it narrows down, and then you see the bladder. And if you do a retrograde filling in this patient, you will see that that's fixed. So you'll not be able to cause pressure to dilate it. And here again, you can try an endourological treatment, 10% success rate in the 3 or 4 patients that we have, or an open resection. You just open up, cut the piece out, and readapt your afferent tubular segment, and that was 100% successful. And interestingly, I just found a recent publication from USC where they had the same problem with their afferent limb mechanism for the T-pouch, where there was stenotic there. And this was the one case they reported. They tried endoscopic dilation, didn't work, and then they revised the limb, and the patient was cured. Stones. So upper tract stones are not that common. They're somewhere around 2 to 5%, depending on. Neobladder stones, they are reported in the literature. As I mentioned before, we have never had a neobladder stone. And I think this, again, is our management of patients. We force them to evacuate and rinse the bladder. If they have infections, we try and find out why and try and treat it. and how anybody who is on regular follow-up can develop a stone that size without the urologist finding it surprises me. It's a recent publication from the New England Journal of Medicine. On the other hand, continent cutaneous diversions are more difficult. They have more stasis and they tend to have more stones. What are the risk factors for the stones? And this is probably why continent cutaneous have more problems. Bacteriuria, recurrent infections, non-compliance with irrigation. Sometimes patients will get tired of irrigating. That's what I was trying to say. You have to see them all the time and keep telling them, you know, you really have to do this, otherwise you're going to have some problems. Mucus, if mucus gets plugged, the bacteria will sit in the mucus and then you're going to start to get your stone generation. And the worst thing of all is foreign bodies. Any foreign body in the urinary tract over years is going to cause some problems. And you can see these patients come with these big massive stones sitting in their neobladder. And there's actually a study showing that irrigation reduced the risk of continent cutaneous pouch stones from 43 to 7%. How do you treat it? 3 options: endoscopic through the continent channel, percutaneous lithotomy, or an open removal. Small stones, you can go in through the channel, but you don't want to spend a lot of time going back and forth because these channels are a little bit sensitive and you will end up with a stricture, and that is a much bigger surgery to improve. Percutaneous lithotomy works, but if you have a big stone, although with all these lasers getting better and better, it might improve. But if the patient is lying there for 3 or 4 hours and you have a continent cutaneous with an open system, you're continuously pushing water up. You really have to be careful to not overfill the bladder. Patients will go home and have fever. So in big stones, I think open removal through a midline incision. I do it in 20 to 25 minutes because my pouch is right behind the abdominal wall. Catheter in for 5 to 10 days, and they can go home with the catheter. And you leave no residuals because these patients have a really high risk, about 45%, of getting stones again. So if you can completely remove the stones, it's a much better option. And just talking about staples, people still use staples. Don't use staples for any kind of continent urinary diversion. These staples always find their way into the bladder. And then these stones sit on every little staple. I've gone in and tried to pull them out. You pull on one staple, 5 others come back. So you're not going to get rid of the stones. You really have to go in and remove the staples. And in the CT scan, you can actually see the channel. They're sitting there, these little points all the way along the cutaneous continent channel. A recent publication, percutaneous cystolitholapaxy is safe and effective in adult patients. Stone-free rate was about 90%, a rate from 85 to 100. The stones are mostly infectious stones, a higher rate of infectious stones than the general population. As I mentioned before, a high recurrence rate. The complication was fever. That goes back to what I'm saying. You have a very full reservoir. You're pressing it all up into the kidneys, and a long operative time of 1 to 2 hours. So if you have a patient who already has decubituses, a neuro patient, you don't want them lying on a table that long. A recent referral, 25-year-old female. She presents with sudden abdominal pain out of nowhere. Nothing remarkable, except she's one of these people that's going on fasting. She only was drinking oat milk and fruit juice. She took some metamizole. It helped a bit, but then it got worse again. So she went to the emergency room. She said the pain was a bit like menstrual pain initially, but then it got much stronger. She presented in another hospital in the emergency room, painful abdomen, no peritonitis. Pain was mainly above the symphysis. She had a history of bladder atrophy and bladder augmentation with a Mitrofanov. And she said, I had no problems catheterizing, nothing different, just all of a sudden I had this pain. They put her through a CT scan. It's pretty impressive. You can already see there's a lot of free fluid in the upper abdomen. As we go down, kidneys are fine, not dilated, more and more fluid. And then we come down here and we see this strange configuration. And maybe here you see a little bit of leakage out. So this patient had a rupture of her augmentation, and she came to us with a helicopter. Put a catheter in place through her Mitrofanov, told the nurses to rinse it every 6 hours, drained the lower abdomen with a drainage, found choline there, treated her with antibiotics. The drain in the abdomen didn't stop bringing any fluid after about 2 days. We removed it. She was rinsing. It worked well. We sent her home, said it's important that it's always on drainage. You really need to keep it empty so it gets a chance to heal conservatively. She came back after about 2 weeks. She had some slight pain again, no free fluid. Told her again, continue rinsing. After 4 weeks, I did a cystogram. It was completely tight. Last week, she came for a 3-month follow-up. She's doing fine. It's really, really rare incidents. That's the second one I've seen in my whole career. The first one was a young paraplegic who was out drinking with his buddies. And they had the good idea to carry him down the stairs to a bar that was down there, and they dropped him on the stairs. And his full pouch just ruptured when they dropped him, and he came in. But otherwise, I have not seen any. Causes are considered traumatic catheterization, which our patient didn't have, an overfull reservoir, or blunt abdominal trauma. The diagnosis is actually relatively simple with a cystography. Obviously, you can do a CT scan. They do have increased creatinine because of reabsorption. And treatment options are conservative or surgery. In the literature, about 20% report conservative treatment and 80% go in for surgery. To discuss it with the patient, my patient was willing to give it a try and was actually quite happy not to have her 5th or 6th surgery after bladder exstrophy. Last but not least, we have outlet complications. That's a known problem people shy away from. Incontinence in about 15 to 30%. Stenosis is a big problem. Luckily, stenosis is usually at the skin level. Tunnel strictures are less common in 15%, and some prolapse in a low number of patients. And these are actually pretty easy to deal with. So you see here on the one side a prolapse, on the other a granuloma, which you often see if you implant right into the middle of the umbilicus. In the meantime, I go a bit more lateral into the soft tissue, and you see these sort of kiloweeds a lot less. Put in a catheter, local anesthesia, and you can remove this in the outpatient clinic. Leave a catheter in for 2 days, tell them to rinse the bladder, and they will be fine. And the same for the cutaneous strictures. They can be treated easily in an outpatient clinic or even in your clinic. Local anesthetic and a Mercedes star incision, catheter for a couple of days. These patients can take it out themselves and go back onto self-catheterization. So once again, continent urinary diversion has a significant risk for complications. They do occur up to 60%. The common ones are infections, incomplete emptying, stones, and strictures. And long-term surveillance is required to identify and treat these complications in a timely fashion. And timely is probably the word here. These patients just need to be followed and kept an eye on. And the more you follow them and act rapidly and treat the things, the better they will do. Thank you.